All right. Good morning, people. We are really excited to have Professor Kevan Polkinghorne from the Monash Medical Center in Melbourne present to us on vascular access. So Kevan is the Deputy Director and Head of the Dialysis Program at Monash Heath in Melbourne. He's a professor in the Department of Medicine as well as the School of Public Health and Preventive Medicine at Monash. He's done his clinical training in New Zealand and Australia, and he has a PhD in clinical research and epidemiology with research interest in hemodialysis and what he's going to talk about on vascular access, as well as home hemo and treatment modality comparisons and CKD epidemiology. Welcome.
Thanks very much for the opportunity to talk today. Sorry about the problems at the start. I've titled this talk Musings about Vascular Access, and really I'm going to talk about catheter care and complications. And essentially, it's mainly going to be work that one of my PhD students did, Dr. Ben Lazarus, one of our fellows and PhD students who completed a PhD on a lot of work related to the reduction studies. So that's really what I'm going to cover. Before I start, I just want to acknowledge the traditional custodians of the land in which we meet today and pay my respects to their elders past and present, and I extend that respect to Aboriginal and Torres Strait Islander peoples here today. So I want to talk about catheter complications. This is probably my favorite catheter complication from the literature that I know of. This was an article, I can't even remember how I came across it. It was a long time ago, of a woman who decided to cut her partner or husband's catheter while he was having treatment at home. So home dialysis can be a dangerous thing, especially with a catheter and a knife. So I'm going to briefly just go over some epidemiology of vascular access in Australia, only just to give you context of where we're at. I actually quite interested in practice patterns over the years, and vascular access is one of those things that there seems to be vast differences between countries, despite a lot of countries having very similar healthcare systems, and Canada and Australia is one that really strikes me as a pivotal example where our health systems are very similar. You know, we have majority in public health care, all that sort of stuff. We do a lot of home dialysis, yet our vascular access patterns are probably quite different. And I've always wondered why that is. I don't know the answer, but it is interesting to me. Then I'll talk about infection, what's an acceptable rate, and then really focus on some hospitalization morbidity data that we found in our reduction study, and then go on and cover catheter dysfunction and patency rates, some issues about design, catheter care, and replacement strategies that hopefully will be of interest to you all. All right, sorry. So let's brief epidemiology. Well, in Australia, as you know, we have a national registry, and so this is what broadly our access rates look like as a country. Patients, about 40% of patients commence dialysis with a fistula, and the rest basically with a catheter in the main tunneled line, but a good 10% start with a non-tunneled line, and then subsequently most patients, about 78% to 80% get a permanent access, mainly in fistula, and we don't tend to use a lot of grafts. But the prevalent catheter rate has been increasing over time, and it's around sort of 18 to 20%. The only other point I would note about this is the relationship between access type and age, and these are just the crude percentages again. And when you look at incident rates, it's actually the younger people who are starting with catheters as opposed to the older people, which we'll come to a bit later, is a bit paradoxical in some ways. But you can see that most patients, irrespective of age, get converted to a fistula, although that particularly young group don't. And that's a reflection of the pediatric patients, of course. This was the only recent data I could find from Canada. This is from your core registry, but I only just understand that it's no longer a national registry, I think. Is that correct? Not everyone contributes anymore. Um, and just showing that you guys love your catheters, I think was fair to say. Certainly at the start, and I don't know what the prevalent rate is. I couldn't find any data on that. Maybe I didn't look hard enough. So that's something that I could be interested to find out from you guys perhaps at the end. So practices are different. And this always was a sort of quote from you guys, your colleagues, I think in Ontario, and this was quite some time ago, really making the point that the dogma that a fistula is the best thing for a patient is not necessarily the right thing, and really raised the point that, in our older patients and sicker patients, maybe we should be using a catheter. And in fact, they proposed to do a trial, and I think Rob Quinn and co did do a trial, but it failed, unfortunately, I think, to recruit to target. And I think we even tried to join it in Australia, but it really just fell over, unfortunately. And so I actually think we're in the era of catheter first, and we've been in the era of catheter first for about 20 years. But there's a lot of pushback, especially from America now, about the problems that fistula first created with the reliance of trying to get fistula in people and overdoing interventions. And so we really don't know what's best for patients at the moment. And finally, the KDOQI guidelines led by Charmaine, who's also Canadian, it's basically all Canada pretty much, isn't it? Really makes this point about sorry, my other computer's causing my problems now. Sorry about that. Made the point that we should be tailoring the access to the patient rather than just being dogmatic about what's best, fistula, graft, or even catheter. So let me talk about infection, and then I'll bring back to that life plan a bit and talking about some data we have. But I have to do a bit of a sidetrack to introduce the reduction study, because this is pretty much the study that's derived of all the data I'm going to present later for you. Reduction was a multifaceted interventional study where we developed a whole suite of catheter care interventions and performed a sort of step wedge cluster randomized trial in 37 units across Australia to really see if this intervention based on catheter care procedures could help reduce bacteremia rates. And the study went for a good 3 to 4 years. It included about 80% of all the units in Australia. And we had sort of 3 tranches of randomization to the intervention. We were interested in having a very concrete definition of bacteremia, even though we also collected data on all events, but in the study for the actual main outcome, we had central adjudication with a blinded committee to confirm bacteremia related to the catheter. And sadly, all that work didn't actually make any difference to the intervention rate, which we published a few years ago now in the BMJ. But one of the things we're interested in is rates and burden of infection. So it's not clear to me really what an acceptable rate of infection is. And KDOQI sort of state a rate of about 1.5 per 1,000 catheter days is what most units should aspire to and should really be, collecting this data and monitoring their rate. In reduction, we had much lower rates than we expected, actually, which was, I guess, a good thing, although I remain suspicious that we had underreporting in the trial. But it was surprisingly good considering we thought we had a real problem when we first were thinking about designing the study. But when you look at rates within units, there is wide variation. So similar to other issues around practice patterns, there's wide variations in the bacteremia rates depending on which unit you looked at any time during the study. So this graph shows that, and the size of the unit reflects the size of the circle, but you can see that there was variation between 0 in the various study phases up to around 1.8. But over time, throughout the study, the rates came down. And the risk was highest in the early days of the following the catheter insertion, which is not probably news to you. And over time, around over 1 year, around 10% of catheters are removed for definite infection. But what about morbidity? And this is where I think Ben and I were quite interested in trying to sort out. So we were really interested in how much infection there was, how it was distributed amongst the population, and what was the burden. And so we did some work and got this published in the Medical Journal of Australia. So not a nephrology journal. We couldn't find any interest in a nephrology journal for this, which is quite interesting to me. But there was completely non-interest in the journals looking at it. So we were interested in just looking at the burden of hospitalization for infection. So people who were hospitalized, we linked all our cohort to hospitalization data. And we used our stricter definition of bacteremia because we were interested in what's the pure morbidity of someone who comes in as a result of Lyme sepsis. So they weren't admitted for another reason and got Lyme sepsis or whatever. This was purely the principal diagnostic code for their admission. And that had to be made within 3 days. The trial the bacteremia had to be reported within 3 days of the admission, or before or 2 days after. So we really were keen on looking at that pure concrete group to see what actually happened to them, in addition to the others as well, which I'll show you in a moment as well. And what was interesting, so this is a graph of all the infectious admissions that occurred during the trial and all the patients. And you can see that if you take our strict definition of the primary cause for their infective hospitalization, 8.2% of patients had an admission for bacteremia, which comprised of about 11.5% of the total bed days. But if we look at the next group, the orange group there, which is a group where the coding was ambiguous, and they weren't documented as a primary infection and reduction. So in the ICD-10 codes, we see a coding of a vascular access infection, but we don't know any more than that. And you can see that about 25% of the bed days and admissions are related to the catheter device in these patients. So it's quite substantial. And when we look at the microbiology, there was, in the main, Staphylococcus aureus and Staph species causing more than 50% of the infections, so particularly virulent organisms. And then about another quarter were gram-negative bacteria as well. And this differed actually to a most recent study from the US, where the proportion of staph infection was less, about 46% in total. So I'm not entirely clear why we were different or why they're different to us, but there's certainly differences across countries in terms of pathogenic organisms and catheter bacteremia. Oops, sorry. So the other thing that we were interested in is, oops, sorry, what happened to the patients? I'm having trouble with my Zoom. I'm only on one screen because of my computer not working properly. So when we look at the median time to removal for the catheters, it was about 2 days. But what was really interesting is that in about 25% of the patients that had a catheter removed, they didn't actually have a new one put in, implying that they had a functioning access that could have been used anyway. In other words, the catheter probably shouldn't have been there in the first place. The median length of stay was about 10 days, and you'll see that there was a significant amount of metastatic complications at about 7% of patients having a metastatic complication from their bacteremia, and a substantial amount, a proportion of patients also were admitted to the ICU with 4 deaths amongst that pure group. So the other aspect about it, when we looked at all the bacteremias, so not just the community ones, but include every infection, one of the key things that we found was that it was the young patients that had a higher risk of infection, and they were 1.5 times more likely to have a bacteremia compared to the older patients. So they were disproportionately affected. And you can see that there were 4% deaths in those patients. Now, which is, quite substantial given the age of these patients. And in addition, it was the younger patients that were more likely to have Staph aureus bacteremia rather than the older patients. So the younger patients were getting more bacteremias, and they were getting the more pathogenic organisms, which was pretty concerning. And if you had a Staph aureus, you were in hospital longer. On average, after adjusting for everything, was about 2 days longer. But you can see the actual median length of stay on a crude basis is quite substantially longer, at 12 days versus 7.5. So the key message for us was that these patients who were coming in with community onset bacteremia had quite a lot of morbidity. They accounted for quite a large amount of hospitalization caused by primary infection. They stayed in hospital a reasonable length of time. A lot of them needed ICU. And so we've really had a lot to gain by trying to prevent these infections occurring in the first place, which we're all trying to do, but I think there's a way to go for improvement. And it gets back to this right access at the right time for the right patient, because it's the young patients that are getting affected here, yet these are the patients who in theory shouldn't be using a line in the first place. And if we look at, this is unpublished data that I got from ANSData and put together, if we look at line use over quite a substantial period of time, basically 75% of the patients who start with a line are actually young, less than 73 in Australia and even younger in New Zealand. And if we look at the sort of predictors of that, and if we take out the patients who were late referred, so in other words, these figures only reflect the patients who were known to nephrology services at least 3 months prior to starting dialysis. It's still the young patients that are starting with lines. So I think certainly in Australia and New Zealand as well, we're not doing very well in getting things right for our patients. So the real world catheter use in our patients is not reflective of this personalized approach from KDOKI. And in particular, the young and patients and females were more likely to commence with a catheter. So it's a real problem. So why are they disproportionately affected by Staph aureus? Well, I don't know if we know. What we showed was not necessarily new. It could be that just young people are more active in the community. That could be a factor. The line's moving around, easier to get it infected, perhaps. Greater sweat gland capacity, potentially higher rates of nasal colonization, but we don't really know why they might be more predisposed to Staph aureus than elderly patients. This was a big surprise for us, and I think early identification and removal of lines is really important, given that we had a substantial number of lines that were removed and were never replaced. So implying that we were dragging our feet in identifying patients whose access was ready to go, and we need to get that line out. And so that's a pretty simple thing to prevent as well. So I'd like now to talk about dysfunction or patency, basically, catheter patency. And Ben and I, with Charmaine and Louise, wrote a review for Jason just recently on this topic. This here's not news to you, but obviously we differentiate between early or late dysfunction, and by late we mean after 7 days. That's not particularly late, but essentially, as you all know, early catheter dysfunction usually relates to either a kinking in the catheter or a malposition, usually, whereas late relates more to this bane of our lives, catheter thrombosis, fibrin sheaths, extraluminal or intraluminal. What is interesting is there's not a lot of work out there on catheter dysfunction, patency complications, certainly not in sort of what I would say contemporary, and by that I mean sort of the last 10, 15 years. In the early days, there was quite a range of patency estimates between 30 to sort of 80% over time of catheters developing problems. But there's not really a clear acceptable patency rate in the literature, I don't think. Kate Oki quote rates that are in literature between 0.5 and 3, but I don't really know what an acceptable rate for a unit would be, and probably most units don't really collect this data anyway. I know we certainly don't, but probably should. Another good study from Canada, I think from Ontario, I think you guys are involved in the study, had a procedure rate related to catheter complications of about 0.78 person years. In reduction, we had a rate of 0.81 per 1,000 catheter days at baseline, and then slightly lower in the convention study. But again, you can see in the graph there was wide variation amongst the units in their rates during all the different phases of the study. I really like this study. This was work. Yeah, this is the work done from Ontario units in Ontario. I think it was 5 units. I think, if I recall, you guys were one of them. And this was probably the best recent study looking at a pure group of patients who only had catheters, and looking at what's the incident rate of the various complications. And you can see that, dysfunction, outflow, inflow problems are substantial. But there's a whole high rate of procedures needed to maintain patency in lines. So this is the hazard for removal for dysfunction and reduction overall. And again, it's similar to the infection graph, where the rate is very high at the start and then falls substantially. And over time, over about a year, there was about a 15% probability that you'd have your catheter removed for dysfunction. So what are the risk factors? Well, here are some risk factors that are clear from the literature, and I've grouped them between modifiable and non-modifiable because we were really interested in what are the modifiable things we can do. Obviously, we can't change much about the non-modifiable complications. So if we look at those that are modifiable, putting in the left and instead of the right side, putting the right side instead of the left. But we were interested in catheter tip design, whether our multifaceted intervention had an effect on catheter dysfunction, and then also about replacement strategies. How does that affect your risk of dysfunction over time? And so in reduction, we had a look at catheter tip design and to see whether this was an important factor in catheter dysfunction. Again, like a lot of things in nephrology, we have really poor evidence to guide us. There were sort of about five trials in the literature that were small and low quality, and so it's really not clear which design. And in reduction, there were these three designs that we had that we used: the step, the split design, and then symmetrical tip. And this graph just shows the type of catheter used amongst the 37 centres, showing that symmetrical tips were most commonly used, but there was a decent amount of variation in the data set for us to be able to look at this. You can see that the split tips were probably the least used out of the three designs. And there were, some centres that used just the one design, but there were quite a few that used all three even, which was interesting. So when we looked just at the raw data, what's the proportion of dysfunction based on whether you had a symmetrical step or split design, there was a signal there suggesting that the step tips weren't as good as the other two designs in the data. And that seemed to be consistent across whether it was the first catheter, the second catheter, or the third catheter or more in the data set. And so these are the cumulative incidence curves for the sort of four major reasons for catheter removal or death, of course. And you can see that basically for dysfunction, there seemed to be a clear difference for the step tip compared to two other designs that was not seen in removal for other complications or infection. So other complications is largely infection, routine removal, or death. And so when we put that into a survival model, we really were able to show that the step tips didn't do well. So these are accelerated failure time models. So the interpretation is the opposite to what you think about in a Cox model. So it's modeling how quickly something happens. And so basically a ratio that's lower means that it's happening faster. And so this is showing that basically the step tips versus symmetrical tips had about a 50% faster rate of dysfunction, essentially, of the outcome. So removal for dysfunction compared to the symmetrical tips. And the same data suggested as well versus the split. And what really is interesting is you can see that as there was more adjustment for service level factors, patient factors, and catheter factors, the actual relationship got stronger, not weaker. And these models were three-level models because as you can imagine, you have the catheter, you have multiple catheters in one patient, all the patients are within a service, and then we've got all the different services. So it's all clustered data, and so you have to account for that. But essentially, it suggested that step tips were not great. And this just shows the hazards by the tip design as well from the model, showing that it's at any one time about the step tips had a twofold increased rate of dysfunction compared to the other two designs. So what about multifaceted intervention? So the intervention that we designed for reduction was obviously aimed more at trying to reduce infection, but a lot of the things that we included, in theory, might help catheter dysfunction, including, the site of insertion, making sure it's put in with ultrasound guidance, etc. And so we looked at this, and I showed you this graph before showing the baseline interventional rate. And essentially, we were able to show that the care package did seem to have an effect on catheter dysfunction, unlike what we showed in the main trial. Now, of course, this wasn't what the trial was designed to do, so this is by no means conclusive, but the result was interesting nonetheless. And there didn't seem to be any effect for adjustment either, which was quite interesting. The incident rate ratio remained pretty constant the whole time, irrespective of what you adjusted for. So it may be that if you have this care patients around education of staff and patients and alike, it can make a difference. So finally, what about replacement strategies? So there's no randomized trials for this, and really only a couple of small studies, and suggesting that potentially maybe rewiring a catheter may not be the right thing to do versus removal and replacement. The KDOQI guidelines, based because there's no data, just suggest that it's reasonable to try less invasive measures, including rewiring before you remove the catheter and replace it into another obviously place with a new tunnel. So, and what really struck us in the data set for reduction was there was basically, one could argue, perfect equipoise on this matter. When we look at across the services, whether a line was replaced by being rewired or removed and replaced, we had some units that only removed and replaced the line and didn't do any rewiring. Other units that in the main rewired their catheters, and then a whole group in between. So essentially, marked variation that even accounting for difference in patients was still present. And so we felt that there was real equipoise on what units were doing here. And so this was a great thing to try and study and see what might be the right thing to do. And so Ben did a target trolling emulation. Most of you will be familiar with this sort of method for observational studies to try and, mimic a randomized or hypothetical randomized trial. And some of the previous work has, in not just nephrology but in other settings, suggests that you can mimic subsequent results from trials before by doing this sort of observational work. And so what we did was we identified everybody who had a mechanical failure of their tunneled line, and then only included people who had a line that was either in the right or left IJ, so mimicking as if they would be randomized to have their line replaced or not in the ideal location. So that was sort of like mimicking the eligibility criteria of a hypothetical study. And when we looked at those patients that we selected, there was some imbalance, of course, as you'd expect, mainly in relation to where they were in terms of location or unit size. But interestingly, the age, gender, and proportion with diabetes was pretty well matched before we even did any of the weighting to match to do the actual analysis. And so once obviously we have our weighted population, we had a very well matched group of patients to mimicking the randomization process. And this just illustrates that the standardized mean differences across all the important covariates that you'd want to match on, such as insertion site, who's doing the catheter, what's the reason for replacement, the tip design, etc., which was all pretty well matched. And in the unadjusted work, actually, there appeared to be no sort of difference at all that we could see between whether you had your catheter rewired or removed and replaced. But when we did the subsequent adjusted analysis using our hypothetical randomized trial cohort, there was a suggestion that actually rewiring was better than being removed and replaced, which was interesting because that's not perhaps what we were necessarily expecting. And when we put that into our survival model, there was a trend, but essentially at all time points, there wasn't really a difference. But a trend anyway, suggesting that rewiring was actually okay or favorable. And to my mind, this is pretty good because of it's rewiring, as we know, is easier. So it suggests that maybe we don't need to be, we should just rewire a line in the first instance for these patients. So there's certainly wide variation in practices across Australia, but certainly in our data set, it suggests that rewiring isn't associated with worse outcomes, and so it's obviously advantageous because it's less painful, it's faster, it preserves in particular other options as well. So there's a number of good reasons why you'd want to do it. And it's for providers, it's faster as well and more efficient. So I think, yeah, I'll stop there. So I think we're certainly in the era of catheter first, and have been for years. And while I don't think that's necessarily such a bad thing, with these editorials and Kaidoki really essentially suggesting that we should be putting lines in elderly patients and comorbid patients, which I think that's quite a reasonable approach. But in Australia, I don't think we're doing that, and we've not really been doing that for a long time. And I suspect it's the same in other countries as well. And I think line sepsis is a problem. I think we sometimes underestimate it and perhaps get a bit blasé about it. But it's more common in younger patients who have poorer outcomes because they're getting Staph aureus as opposed to other less virulent infection. And I think that's a real problem. And then finally, hopefully the dysfunction issue is of interest. We don't have much innovation really, and there's certainly opportunities to improve things with thinking about design strategies of catheters in particular, as well as how we approach replacement and things. And finally, my last slide. The lady was actually found guilty of murder. Actually, it was quite interesting. I found this much later. So I don't know. We've certainly had one patient who unfortunately had psychiatric illness and cut her own catheter at home. Fortunately, she was okay, but I don't know if you guys have had any sort of wacky issues with patients with lines at home, but it certainly can happen. And yeah, I'd like to thank Ben because basically he should really be giving this talk, not me. It's all his work really. He just kept me interested. Ben's now in Queensland. He was originally from Queensland. He came down to Victoria and worked with us for many years, was in his training and then his PhD, and now he's gone back there to work at the Princess Alexandra unit as one of their full-time consultants. So which is great. And Shraddha as well, who led the reduction study from Sydney and George Institute, who I'm sure some of you might know. Yeah, and I'll stop there.
Fantastic. Thank you for that excellent overview. We are extremely, as you alluded to, and I'm hoping you can hear me, we are extremely line heavy in Canada and especially in Ottawa, as you know. I was looking up our infection rates and I put that in the chat. It's pretty low. We are at like 0.2 per 1,000 catheter days locally. And in Ontario, the worst center is 0.45. not worst. It's probably luck, as you know, these things
Yeah,
vary.
that's pretty good, isn't it?
Yeah, so maybe that justifies our practice. Maybe there's something about the cold Canadian climate that
Yeah.
helps here. And Manish is on. I don't know if he knows more about COR. I think it is still going on, but I don't see. I was trying to see. I don't see the prevalent AVF rates. You're right about
No.
the incident ones. I think in Ontario we are maybe at least or locally we are about 50% lines. Maybe it's slightly, there may be some provincial variation. I don't know if anyone knows any better data on the prevalent rates.
Yeah.
So
Do
that's
you
the Canadian data. But to go back to your talk and some questions, what do you think explains the young? We have the age trend where we are putting almost all lines in older people. Could it, I'm
Yeah.
sure you've looked at the causes. Could it be that maybe people are waiting for transplants or PD or something like that in the younger folks?
Yeah, those that data excludes people who started PD within a few weeks, So these are patients who are commencing hemodialysis as their primary treatment. Yeah, there may be younger people who have got a preemptive transplant that's lined up and it's just not happened. But the preemptive rates are not hugely high in Australia, so I don't think that accounts for all of it. Um, and as I said, I excluded the late referrals in that group as well. So I don't really know why it's been an ongoing problem in the young patients, to be honest. Um, I'm not sure whether there's a general resistance to think about renal failure in the younger patients. They want to get on with their lives, and it's harder for them to engage in treatment choices and modality. Maybe they were wanting to do PD and then they changed their mind and things, and they don't. I don't really know actually. Yeah.
But it includes it includes the pediatric population too, right? So again, our data is 18 plus, so I don't know, maybe in the under 18 lines are
Yeah,
perhaps.
yeah. So those graphs, I did exclude the younger ones, but that prevalence data is including the pediatrics. Yes, that's right.
Okay. So the catheter dysfunction, I think, is hugely important, right? Because especially as lines, there's a huge amount of cost related to that. So it's something that we should look at with that. I knew that
Do
paper had come by,
you,
but we hadn't looked closely.
yeah, do you guys use what do you use for your locking solutions?
So at our center, we use citrate. We don't
Right.
use heparin. What do you guys use? And was that
Uh,
study?
we're just using heparin. All those other locking solutions, they're way more expensive, and we just can't get the hospital to pay for it
Okay.
because it's part of a hospital expense. It's not a prescription that would then be paid by the government. So basically, so the hospital's like, nah, we can't afford that, so that they won't pay for it.
Okay.
Mm.
Um, yeah, though I don't think, again, this was 15 years ago, and Peter might remember. I don't think we saw a big change, a huge change when we switched from heparin to citrate, but maybe I'm recollecting it wrong. I mean, the rates are so low that it's hard to show, much of a difference with just one
Yeah, yeah.
change. Um, but the catheter types, we do talk about it all the time, and often we will use the split because I think the split is more expensive, perhaps.
Mm,
So we
mm.
only use it when we have changed it a few times and someone is having problems. So there's a selection
Yeah,
bias in our case when we use the split.
yeah, yeah. Yes.
Yeah.
Yeah.
It's interesting that you had those three very, very heavy split user centers, which
Yeah.
may have
Well, I
skewed.
think I think in Australia often the hospitals just have a set contract, and so they just
Right.
get one type of catheter. And most hospitals are a bit like that, so they don't tend to vary. They don't get more than one provider often, so that's why you saw that. But there were quite a few there that did
Yeah.
have both. So
Yeah.
some.
So I think we are
Mm,
similar, which is why the split is way more expensive, right? Because it's like a special order. or something.
Yes.
Yeah,
Yeah.
Peter, I think you want to ask or say something.
Yeah, a couple of comments and then a question. We did change years ago to citrate. At the time, there was some research, I think maybe from Charmaine, that suggested lower infection rates with citrate. Citrate was
right.
not more expensive than the unfractionated heparin we were using at the time. And we also had a few episodes of big bleeds when we used quite high dose unfractionated heparin, and it turns out that people were leaving the unit fully heparinized, and we had a couple of fatal bleeds.
Right.
You mentioned the cutting the catheter. Well, we had one when I was on service where somebody walked into their room in the hospital and the guy had gone to the bathroom and cut his catheter, and it was fatal. And whether it was psychiatric or suicide, not quite clear.
Yes.
But he had been unhappy with
Yep.
dialysis, and maybe we should have been listening to him more about his unhappiness. A question, another thing with line function, nurses end up being addicted to TPA. And as soon as a line isn't working well, they want to use TPA, and we have a huge expense in that. And I'm always skeptical about how much difference it makes. And we basically go usually through weeks of expensive TPA before we bite the bullet and get the line changed, usually over a wire, at least the first time around.
Yes.
What's TPA use like in Australia, and what's the policy you're feeling about that? And does your hospital like pay for it?
Yeah. Yes. It's all hospital specific because the hospital has to pay. We are discouraged to use it. We try to limit its use. It's really expensive. So probably similar to Canada, it costs a fortune. So we really are using it, for as little as we can. And I agree. I'm not entirely sure it makes a lot of difference, but I think and the price has just gone up. I think it used to be $80 for a 22 milligram vial, I think, and now it's $180. And our hospital's use has gone up, by $600,000 or something in a short space of time just because of the price hike. So the hospital's really worried because the budget's being blown. Yeah.
The only note about the TPA is that funnily it's one of those only areas where we have a randomized controlled trial.
Yes.
Showing that not only does it, I think it lowered mortality, if I'm not right. The Alberta trial showing that once a week TPA, but of course the background was heparin, it wasn't citrate, and it was driven perhaps by infections, and most of us didn't believe it or said, hey, this is too expensive and our infection rates are low, so let's not do it.
Yeah, that's right. And a lot of people often don't read it carefully and lock it every time. They don't realize that it was just once a week too, I think at times. But it's we couldn't get it past our pharmacy committee to use it regularly like that. No way.
Yeah, we wouldn't either. Our hospital budget would not allow us to do that. There's a question from the conference room.
Thanks, Bob. It's Mark here. Thanks very much, Dr. Polkinghorne. Enjoyed the talk. One of the things, do you have data beyond 2020? Because one of the interesting things in late 2020, 2021 was that infection rates in hospital went down. Not, we did see it in our dialysis unit in terms of infection rate, catheter infection rate, but kind of across the board, which presumably reflects more attentive hand hygiene and less movement, etc. And like a related question to that is in the supportive or intervention bundle for the trial, like how much of that was sort of allied health or program related versus what patients can do for themselves? Just, as a related question to that natural history of less infections when people were washing their hands.
Yeah. I don't have data more recently in Australia, but the ANZData registry it's just commenced in the last year to actually collect bacteremia rates in dialysis access. So all the units are going to be reporting that from this year basically. So we'll have national data that'll be regularly updated. So we'll get what our rate is, and we'll obviously have a look at the comparison. So yeah, it'll be interesting to see whether that's lower. Because I think you're right. That's one thing the COVID pandemic did was focus our attention on infection much more than we used to. In terms of which parts of the bundle I think helped, it is hard to know. I mean, I can only speak for my unit. I think we had sort of patient education package I think was good. And also just the general focus on catheter care for everybody, the nursing staff, the doctors, and the patients. I think probably that general focus is the thing that helped. But I don't really know which aspects helped because we didn't have any questions around that, unfortunately, because we just didn't have the money. It was already run on the smell of an oily rag, that study. So I can't really answer that very well for you, unfortunately.
Thank you.
So going back to that last topic of the target trial emulation, where you had the paradoxical unexpected result. Again, I should read the paper really, but while I have you here, was there any speculation about why, like for example, we usually rewire. So I love the result because we rewire and we don't replace for catheter dysfunction, right? It's a different story if it's an infection.
Yes.
And I wonder if it is like, is there any way to capture the fact that perhaps we only replace if it's a difficult situation where we have tried several times, or something else is going on while we rewire?
We tried to look at was there any pattern. So it gets to that first graph where there was a clear, sort of a 45-degree line showing proportions of rewiring versus not across centers. And we really couldn't find any clear guide that suggested that there was a reason why people might be rewiring in different situations versus not. But I can't explain why the results suggested not quite the opposite of what we were expecting, but the fact that rewiring was okay. It's reassuring, I guess. It's good, isn't it? Because clearly it's an easier thing to do. It's the problem with these large trials. We've got information, but it's always not quite enough information to really get to the detail of things when you ask questions. But yeah,
no, that's good to know. And reassuring, like you say, it's like we don't have to change practice and do something more expensive, which is always a result we like.
That's right. That's right. I mean, it's surprising that no one's ever thought about doing a study for this proper trial, all these simple questions, but they never get answered really.
Yeah. So Manish is replying in the chat that, as we expected, we are about 80% lines for incident in Canada, and we are 60%. I was thinking 50, but we are 60% for prevalent for CVCs versus AVF, AVG. It's pretty high. Yeah.
The other thing, I was recently in Japan, and I went to a dialysis unit there. It's 100 bed unit because they use beds. They don't use chairs there, so there are 100 beds. And I went and saw a patient who was 94. She was a 94 lady, been on dialysis 14 years, and was dialyzing with irredeocephalic fistula. And basically, there were all these patients who were very elderly dialyzing with fistulas. They were just not a line to be seen.
Yeah.
So, it's really interesting how different various countries are, and the patients aren't that different. I mean, yes, they were dialyzing a lot older people than probably we would in Australia, but they had the same comorbidities, you know.
Yeah.
She was 44 kilos, you know, a little tiny lady, you know.
Yeah. And that's the other thing. I mean, I think wasn't Japan, the results from Japan, one of the drivers for doing DOPS in the first place, because they saw, you know, it was such a huge variation between US and Japan.
Yes,
back.
I think that's right. That's right.
Yeah, it's very interesting. Like it's a different culture though. I think they run. Am I right? They run fistulas with like flows of 200 or so usually, whereas, you know, we run 300, 350.
Their flow rates are a little bit lower, but I don't think that's a big deal. I mean, their fistulas look pretty normal. You know, you could probably dialyze people a higher rate there. It's just that they don't need to, I guess, because they tend to be smaller people.
Yeah, fascinating. The regional continental country differences are fascinating. I don't know how much we can learn, but you know, there's always.
I know.
Yeah. Anyway,
it's always interesting.
It is very interesting, especially like you say, the Australia-Canada differences are fascinating.
That I think is really interesting because our healthcare systems are pretty much the same, and we practice much the same, you know, and often I think, but there are certain areas where we are very different, and I don't. I'm always interested to know why, just because you can learn from other people that do things differently, you know.
Yeah, absolutely. Yeah. Anyway, on that note, we are almost at the hour. So thank you again for, I don't know, what time is it there in Melbourne?
It's midnight, coming up to midnight.
Thanks for staying up so late for us. I hope you have an easy day tomorrow. I'm
actually flying to Sydney in the morning at 7 for midday, so I've got to be up early.
Yeah, we should wrap up. Yeah, let you get some sleep. Thank you.
No problem. Take care. Bye-bye.